Hello everyone. In this video, I will tell you about the etiology and pathogenesis of oral lichen planus. Lichen planus is a chronic mucocutaneous disorder of the stratified squamous epithelium, and it affects the oral and genital mucosa. It also affects skin and nails. An English physician named Erasmus Wilson first described lichen planus in 1866. In 1895, Wickham noted the characteristic white lines on the surface of lichen planus, and these are now called Wickham's striae. Let's now go to the etiology of lichen planus. The exact etiology of this disease is still unknown, though some factors are thought to be associated with this disease, and these factors include: first, genetic background. The human leukocyte antigen, that is HLA, is found to be increased in the patients suffering with lichen planus. So HLA A3, A11, A26, A28, B3, B5, B7, B8 and DR1 are found to be increased in the patients suffering with lichen planus. Certain dental materials including silver amalgam, gold, cobalt, palladium, chromium are also associated with oral lichen planus. It is also seen that prolonged use of denture may be associated with oral lichen planus. Certain drugs including non-steroidal anti-inflammatory drugs, beta blockers, ACE inhibitors and certain contact allergens like the flavoring included in the toothpaste, especially cinnamon, may be associated with oral lichen planus. Various infectious agents, for example, spirochetes, H. pylori and candida may also be associated with oral lichen planus, though their association is not yet confirmed. Some studies have suggested a strong association between hepatitis C virus and oral lichen planus. Certain food and food additives such as cinnamon and aldehyde may also be associated with oral lichen planus. Habits like cigarette smoking, betel nut chewing have also been suggested as an etiologic factor. Diabetes and hypertension have also been suggested as an etiologic factor. The triad of diabetes mellitus along with hypertension and oral lichen planus is called Greenspan syndrome. Stress is also proposed as an etiologic factor. Let's now go to the pathogenesis of lichen planus. It has been noted that in patients suffering with oral lichen planus, there is an increase in various cytokines, and these cytokines include TNF alpha, IFN gamma and IL-1. TNF alpha is tumor necrosis factor alpha, IFN gamma is interferon gamma and IL-1 is interleukin 1. These cytokines stimulate the endothelial cells of the subepithelial vascular plexus, and this in turn leads to an increased expression of the vascular adhesion molecules, that is CD62E, CD54 and CD106 by the endothelial cells of the vascular plexus. Also, there is an expression or unmasking of an antigen on the basal keratinocytes, that is the epithelial cells of the stratum basale. These antigens may be a self-peptide or a heat shock protein. These vascular adhesion molecules and antigens on the basal keratinocyte act as chemoattractants, due to which the T cells, which mostly include CD8 positive and there might be some CD4 positive cells. So these T cells migrate into the epithelium. The CD8 positive T cells trigger apoptosis of the basal cell of the oral epithelium, that is basal keratinocytes. The normal integrity of basement membrane is maintained by a living basal keratinocyte, as it secretes collagen 4 and laminin 5 into the basement membrane, and these collagen 4 and laminin 5 are the forming elements of the basement membrane. The keratinocyte, on the other hand, requires a basement membrane derived cell survival signal. This cell survival signal prevents the onset of apoptosis of this basal keratinocyte. So when the CD8 positive T cells induce apoptosis of basal keratinocytes, It also leads to basement membrane disruption, as the collagen 4 and laminin are not supplied by these epithelial cells anymore. And the degenerated basement membrane in turn cannot supply this cell survival signal. So, this condition is further worsened. The degeneration of the basal keratinocytes and disruption of the basement membrane weakens the epithelial connective tissue interface. So, the junction between the epithelium and the connective tissue is weakened. And because of this weakening, there is a development of cleft at this interface. And these clefts are called Max-Joseph spaces. So this was all about the pathogenesis of the oral lichen planus. Let's now see a quick recap of this pathogenesis. The increased expression of cytokines stimulates expression of vascular adhesion molecules and unmasking of antigens on the basal keratinocytes. This leads to the chemoattraction and migration of CD8 positive T cells into the epithelium. These CD8 positive T cells cause the apoptosis of basal keratinocytes, which would in turn lead to degeneration of the basement membrane. So you may say that oral lichen planus is a T cell mediated autoimmune disease in which the auto-cytotoxic CD8 positive T cells trigger apoptosis of the basal cells of the oral epithelium. So that was all about the etiology and pathogenesis of oral lichen planus. I hope you like this video, and if you do like this video, please like, comment and share, and please don't forget to subscribe. Thank you.